Hello, everyone. I'm Rosalind Mannon. I'm professor of medicine in the Division of Nephrology at the University of Nebraska Medical Center in Omaha. I'm also a deputy editor for the American Journal of Transplantation, and I want to welcome all of you to the inaugural AJT Journal Club on the topic of T-cell mediated rejection. Tonight, I'm joined by an esteemed panel of associate editors and experts on this topic. And our goal tonight is really to enhance discussion about the papers in the journal, but also to enhance potential conversations and future research interactions. Let me go ahead and introduce the panel. I'm joined tonight by Sindhu Chandran. Dr. Chandran is an associate professor of medicine in the Division of Nephrology at the University of California at San Francisco and an associate editor with the journal. And I'm also joined by Michael Mengel, professor in chief of the Department of Laboratory Medicine and Pathology at the University of Alberta, and also an associate editor. And our two guests tonight are Philip O'Connell, professor of medicine and transplantation and the executive director of the Westmead Institute of Medical Research at the University of Sydney, and his colleague, Dr. Jermaine Wong, who's also professor of medicine as well as clinical epidemiology and the director of kidney transplantation at Westmead at University of Sydney. Tonight, we're going to be talking about two of the March published manuscripts on T-cell mediated rejection, the study by Ho et al. On the effectiveness of T-cell mediated rejection therapy, a systematic review and meta-analysis, and the study by Rappersand and et al. On the negative impact of T-cell mediated rejection on renal allograft survival in the modern era. Now, hopefully all of you have had an opportunity to read these papers. And also there's a recorded YouTube as well. And this gave an opportunity for Dr. Ho and the senior author of the Rampersad paper, Dr. Wiebe, to give them a 15-minute overview of what their paper, the methods, what inspired them to write the paper, and their overall conclusions. So if you haven't done that, don't worry. We'll try to keep you caught up. But if you have a chance to go back, please, that link is open. So why T-cell mediated rejection? I think certainly the frequency of T-cell mediated rejection, most of us know, is about 5 to 15% of clinical rejection in the first year after transplantation in the modern era. And as many of you know, this is a vanishing endpoint for clinical trials. And it is really limited the opportunity to develop new immunosuppressive therapy, and I think sometimes gets somewhat overlooked. Meanwhile, many of the centers that do surveillance biopsy have noticed a 20 to 30% subclinical rejection frequency on surveillance biopsy. And whether to treat those episodes or not has continued to be a point of debate, certainly showing that untreated subclinical rejection leads to worse outcomes. With regards to treatment, there are treatment guidelines for KDIGO, for example, but recent survey data in both Canada and the United States have indicated a number of interesting observations. One, that there's been limited clinical treatment of borderline rejection. Secondly, that there has been inconsistent use of therapies, particularly T-cell depleting therapies, and inconsistent application of that therapy based on Banff grade. And the success for treatment of rejection is defined primarily by the return of function in 70 to 90% of individuals that responded to the survey. And by biopsy, in a minority, only about 30 to 40% of individuals that responded to the survey actually perform a biopsy after rejection. So these two studies really address a couple of questions. The first by Ho et al. Following treatment, how often does T-cell mediated rejection persist? And whether the persistence of rejection is related to the initial Banff grade, and whether the absence of clinical functional change matters, meaning if it's subclinical TCMR or for-cause TCMR, does it really matter? And using a systematic literature analysis, they identified 12 studies for their meta-analysis. And noted that after treatment of greater than or equal to Banff borderline on the initial episode, almost 40% of individuals had persistent rejection of at least a Banff borderline, regardless of the grade of the primary event. Moreover, after treatment of Banff borderline subclinical, 46% of individuals had persistent at least Banff borderline rejection, whereas 41% had clinical rejection persistence. So regardless of whether this was surveillance biopsy or clinical biopsy, the frequency of persistent rejection was nearly the same. And what is the overall impact of T-cell mediated rejection on long-term survival? In the olden days, like 20 years ago, we noted a sharp association between T-cell mediated rejection and outcomes, but over time, we saw somewhat of a dissociation. So in the paper by Rampersad et al., this was a monocentric study of tacrolimus-based immunosuppression of 1,600 biopsies from about 500 patients, and half of those biopsies were surveillance. Greater than 50% of recipients with T-cell mediated rejection ended up having another rejection rate. In fact, in that paper, there were actually individuals that had 8 to 10 episodes of T-cell mediated rejection based on biopsy. And the group noted that there was a relationship between HLA, DR, and DQ molecular mismatch. So higher grades of molecular mismatch were more frequently associated with recurrent T-cell mediated rejection. And finally, using an extended proportional hazards model after adjusting for baseline covariates, both first and second T-cell mediated rejection events were independently associated with death-censored graft loss. And the second TCMR episode had negative impact on both death-censored and all-cause graft loss, regardless of whether it was considered a persistent event or a subsequent event that was considered separate independent event where there was a so-called clean biopsy in between. So with that, I'm going to stop my slides. And unfortunately, we're having issues with the video. Please go ahead if you have questions to put them in the Q&A, and I'll try to stop myself from talking for a few minutes and go ahead and include your questions to the panelists. All right, so I want to talk a little bit about the significance, start this conversation about Banff borderline rejection. And I don't want to pick on Mike Mengel, who is, leads the Banff allograft pathology group. But, in thinking about the significance of it, and I'll take this to any of the panelists, do we just assume that Banff borderline is just as an alloimmune response? We look at risk factors, the transcriptomics, and the prognosis being very similar, at least in these papers, to Banff grade 1A rejection. So any thoughts about it? And Michael, you're free to, if you want to ask first.
Sure. Thanks, Roz. Right. I think the question is as old as the Banff process is, so more than 30 years, is what's the significance of the borderline category? And I think Kim Solis is on this journal club and can even firsthand share with us what the conversations were in 1991. But my understanding is that there was always the awareness that minimal inflammation represents the starting point of the continuum of T-cell mediated rejection. And animal models actually reproduce this very well, where you can sacrifice mice on every day post-transplant and see how the development of interstitial inflammation and tubulitis in untreated or non-immunosuppressed and mismatched animals is a continuum. So I think your notion is valid to say that borderline is just a milder version of what we call T-cell mediated rejection at the starting point. However, the rationale to introduce borderline was to avoid over-immunosuppression, which has side effects, right? And I think that is the same question we're challenged with today, is we could load all these patients with minimal inflammation with more severe immunosuppression, but we would pay a price for that. And on the other hand, we now fairly well understand that when we do not abrogate the inflammatory process and it continues and repeats and persists, we have shorter long-term allograft survival. So to me, is where's the sweet spot for the individual patient? So in the era of precision medicine, we try to treat all patients the same way. And therefore, I think we need more understanding of the qualitative characteristics of the inflammation of borderline. And the molecular studies you refer to try to do this and show that half of the borderline cases show the same molecular phenotype than T-cell mediated rejection. And I think that's the direction we have to continue working towards, to anticipate which borderline is more likely to persist and progress. And I think the papers we're discussing here suggest that higher eplet mismatch, so higher immunological risk, is an indicator, for example, for such more persistent or progressive borderline cases.
Yeah, I mean, I certainly think that that the Nickerson group has really aligned a lot of and they show in a couple of papers that the higher risk epileptic mismatch is associated with TCMR and ABMR. But I also wonder if there's, any issue of compliance or, it's hard to sort of know whether, I mean, they did have follow-up biopsy, but I also wonder if, a number of those people that had repeated recurrent rejections were low immunological risk, certainly. And so I just don't know if there's an issue of non-adherence that we're missing here and whether that could be teased out. But again, it's hard in terms of those studies because, that adherence wasn't really commented on in the Nickerson study. We're getting some questions in the chat and anybody can follow up and say what they want. I know it's awkward without the video, but there was a question in the chat and I'm not sure who to pitch it to about the correlation between borderline rejection and cell-free DNA. Does anybody want to take it? I mean, I can say something, but this is a Brosnan monologue and we want to have a bigger conversation. Any cell-free DNA people out there in the panel?
I have cell-free DNA in my blood at a low level. And my understanding from the literature is that even with regular 1A TCMR, the sensitivity of cell-free DNA assays with the commercial recommended thresholds is suboptimal. It's fairly good for antibody-mediated rejection, which we know causes more injury. So my understanding is that borderline cases are under the recommended thresholds of concern for the commercial tests.
And I'll say that in the DART study, which was their landmark study, that my recollection is we did try to do an alignment between cell-free DNA and the grade of BAMF rejection. Now, again, those biopsies were not done from a central pathology perspective. It was individuals that had, their individual laboratories. And my recollection is that there wasn't really, at the very high extremes, meaning like 2B and 3, and there were not many of those cases, so I'll be very cautious, that there was more cell-free DNA. And, but, from the notion of the BAMF borderline, I can't even remember if there were that many borderlines in that data set, but that Jason paper is 2017. I would definitely say to go back. And I've just been signaled by our moderator that we have a video. So, please on mic and don't make me feel so lonely. Perfect.
Roz, what I could say, I've never used cell-free DNA, so I can't comment on that. But I think implied in the question was how we're going to monitor these patients. So if I want to sum up the two papers, I'd put it that they've identified a problem. And that is, what do we do about things that we call borderline rejection? But more importantly, how do we judge whether we've adequately treated that rejection and what that means? Because a third of people, I think in both the observational study and the meta-analysis, roughly a third had persisting rejection after treatment. So in units that do a lot of biopsies, I guess you can do follow-up biopsies, but there's a reason protocol biopsies aren't done everywhere, either for logistics or whatever reasons people can't or don't do that. So they're looking for other tools to monitor effectiveness of treatment. And although you could argue that transcriptomic tests, one form or another, may benefit, that there's been no evidence to show that exist. So I think one way we could look at this, that, this is a call of, Houston, we have a problem here. And it's interesting that towards the end of my career, the one thing I've been doing for 30 years is treat acute cellular rejection. And at the end, we've discovered we don't know what we're doing and how good we are at doing it. So maybe we ought to put a line in the sand here and start looking at some systematic ways to identify, what's the benefit of treatment, what treatment should we use, how long should we use them for, and what do we do with that group of patients that are at risk. I mean, if you've got a high-level applet mismatch, you can't change that. That's your kidney.
Right, right.
So you're going to have to, what do we do with that problem? I don't think we've got data.
No, and Phil, thanks for bringing it into an account that, ageism is a good thing, because now as I get older, I'm like, oh, I read that paper. I remember that. And people say, oh, that sounds really new. And I'm like, no, I just remember something from 20 years ago. But again, when you think about how you learned about how to treat rejection, I mean, my career spanned using grams of solumentrol to being much more careful and thinking, seemingly more careful. But your points are well taken. One, the detection of BAMF, if borderline, and these papers suggest borderline's critical, the subclinical detection. And so one company may argue that the genomics test in peripheral blood is better at that. But the cell-free DNA is probably not a good tool. On the other hand, what's the best way to treat rejection? And certainly the inconsistent use of T-cell depleting agents may be one. And I'm going to transition to a question about induction, right? So Sindhu, you commented to me offline about Rampersand's paper, some of these papers about the fluctuating amounts of T-cell depletion induction, how we all, we use it for high-risk paper. Tell us a little bit about your thoughts about that.
Yeah. And I think I also want to take on one of these questions here about what % of T cells in the BAMF borderline rejection are Tregs, and are we depleting those? I think one of the things, and just to sort of lay some background here, is that, at our own center, where we tend to use antibody induction in almost all patients, so either IL-2 receptor antagonists or depleting antibody induction in terms of thymoglobulin. And this is consistent with the US practice in general, looking at SRTR data, where more than 90% of patients receiving a kidney transplant receive antibody induction. And comparing this to Rampersand's paper, where at that single center, only about 45% or so of patients had received antibody induction and then were maintained on TAC, MMF, and prednisone. It is striking how similar our own sort of data have been in terms of the prevalence of rejection. Both subclinical TCMR as well as clinical TCMR are pretty much in the same ballpark. We looked at our data maybe about 10 years ago or so, and we found that, the incidence of subclinical was actually just about 30%, 29 to 30%, and that the majority of them, again, were borderline, about 22% or so, and 7% ACR, TCMR. So I think that, the data from France also, and both the group in Australia, from Dr. Nankivell's group as well as Dr. Lee Forscher's group, I think overall have shown that under immunosuppression tends to be correlated with the development of this subclinical inflammation, which then progresses to both chronic active TCMR and potentially to interstitial fibrosis. And again, I think the fact that the higher degree of molecular mismatch was identified as a predictor of the presence and of these changes, as well as the persistence of this, pathology, suggests that, it's not really Tregs that are in this borderline rejection, even though this was not, examined in these papers, particularly as, they didn't really look at the histopathology of these rejection in terms of the cell immunophenotyping and discussing which cells were Tregs. So I doubt that the persistence of TCMR that we are seeing is because of treatment, also because they found that subclinical, or at least the borderline change, tended to persist more when it was untreated. The frequency of persistence was closer to 60% as compared to those who were treated. So it would argue against Tregs being a prominent component of this borderline change, and therefore, the persistence of rejection being a paradoxical response to treatment, and more that the fact that the treatment is ineffective at controlling this alloimmune response, and therefore we see persistence. So I think what is striking is that, despite all these different combinations of treatments we have in terms of antibody induction, plus minus prednisone, etc., that we still seem to have quite a prevalence of this phenomenon across different populations, and that it seems to be related to under immunosuppression. The question now is, what is, proper immunosuppression, and how best to balance that against safety potentially in these patients.
Jermaine, we haven't let you get a word in edgewise. Any thoughts about any of those comments? There's another comment in the chat from Stu Fleckner about inconsistent reporting of subclinical biopsies. And I think now there is a concerted effort for investigators to state exactly what they're doing. Now we do have the realignment of BAMF borderline, which I guess happened in, we changed the definition and had a lower threshold. Now we have a sort of a set threshold, which I don't think is going to change. But I do think people are paying more attention, and there's been a couple of papers where they've gone back and reassessed the levels of threshold.
Yeah, no, I can't agree more, Ross. So going back to the issue of treatment, it's so tricky, and we are doing the things so differently across the world. We were just talking about this last night. Steroid starts when you're BAMF 1A or below, when above 1B plus. Many of us, certainly in Australia and also in the United States, are also using these cell depleting agent. But how do you define steroid responsive and what threshold at what time point? I think the last paper was actually published in the 1990s, which was back in the days where we weren't using TAC or mycophenolate. So better treatment is definitely needed, but at the same time, I think better threshold of defining what is non-responsive versus responsive is also critical. And the tools to define that, typically we use a functional measure, be that a serum creatinine or eGFR, but we know that it is a very poor, not so perfect predictor of allograft outcomes in the longer term. Should we add on more factors? I don't know. The possibility of adding a donor-specific antibodies or additional histology, but at what time frame do we define success or do we define unsuccessful? That's another critical, I think, research topic that we need to look at in the future.
Well, Tom Blight-Hansen is suggesting from Canada that maybe this is the time now to look at treatment efficacy in trials based on rebiopsy. I don't know how you guys feel about it. I think, Michael was alluding to, and one of the questions was the biomarkers. And I think, while the companies are really pushing this on commercially in the States, I think they're not ready for prime time, I would say. Obviously a non-invasive biomarker would be helpful, but I don't know if I can answer Tom's question. I don't know how other people feel about that.
I have some thoughts around this, and I don't know whether that is totally crazy or or worth discussing. So when we transplant a healthy kidney, so to say, in often circumstances into somebody, and we then give drugs to avoid rejection, and when somebody has rejection, we give the same drugs. So it's like when you look at cancer, you try to target, treat it, and avoid recurrence. So you want to get rid of it and avoid recurrence. And when it recurs, you treat it either differently or stratify by risk, but you're not treating every cancer in the world the same way. But that's how we started in transplantation. All rejection, all infiltrate. And I think what we just learned by separating out antibody-mediated rejection slightly, way better, not slightly, but way better than in the past. So I reviewed recently the literature about steroid-resistant rejection. Most of those studies are from prior DSA testing or even C4D staining. Mm-hmm. So the definition of steroid-resistant rejection in the context of TCMR, I think, has no real evidence base in today's era, and this is why these two papers we're discussing here today. Don't forget about how well annotated the cohorts are for ruling out DSA, regular visits in a inclusive healthcare system where everybody gets access, right? All the visits. No, don't underestimate how well annotated these cohorts are and how big they are. And they show us that now a more pure T cell population. And to Tom's point, I think that were the prerequisites, the groundwork to do reliable randomized trials of actually treating TCMR, and with the goal of saying, okay, it's a relapse or an episode, but we want to treat it effectively, that long-term allograft survival is not impaired, right? So how do we prevent this going into after in deterioration in function, or even worse, in DSA development, which the Winnipeg group also showed. And I think now where we have a better understanding what pure T-cell mediated rejection is, we can design trials with that focus. And in the past, we tried T-cell mediated or anti-T-cell drugs in full populations with and without DSA, at the very beginning, with and without BK risk, right? So I think Tom's question is timely, and we needed to come to this point to enrich a T-cell mediated rejection specific trial. It's like now in breast cancer, trials are done only in triple negative breast cancer, right? And not in the hormone receptor sensitive ones. So you risk stratify within the disease silo, and I think that can take us to the next level.
So
I agree. Sorry, Phil, you go.
No, you go, Jermaine.
Oh, I just saying, well, just can't agree more, Michael. It's almost like a platform. And I think I mentioned that to Phil and Peter the other day, personalized the risk of each individual participants as they do in cancer trials. You know, in the cancer trial, they're much more advanced because they already have molecular biomarkers. With us, is slightly more premature, but certainly we have other markers such as you said, the donor-specific antibodies, and trial different potential interventions in an umbrella design, or I don't know, a basket design, tailoring according to the risk, and response adaptive to the whole process. But the critical component though is what is the outcome, and I think, I know Phil can chip in here. It's one of the things that we've been struggling to think about, a real good outcomes that is most reflective of longer term graft survival.
So I think Jermaine and I are going to make the same point that goes off from what Michael and Tom brought up, and that is we need to do a trial. And the one advantage of this group is that you've got an enriched population. So even if you just took all people who had first biopsy proven acute rejection to enter the study, from the data we've looked at, 30% are going to have an outcome which is failure to get adequate response. So that's pretty good, much better than what we get in transplantation, where we put thousands of people in a study for very few events and get disappointed because we don't get a meaningful outcome. I think, as Jermaine highlighted, we ought to be thinking out of the box in terms of trial design. We've got a lot of prior data. We ought to be looking at an adaptive trial design where we can incorporate several treatment modalities and drop those off that don't seem to be particularly beneficial, and keep going with those that are. And Jermaine's certainly got much better skill at that than I do. So I think that's really important. The other issue that Jermaine brought it up, well, what's going to be the outcome? So I think we all get bored after a couple of years. So I think we need to have a surrogate outcome. And that would be, we could say we could have a composite of that, the things that we know work, like delta GFR, we know is predictive of graft loss. Development of de novo DSA is predictive of graft loss. There are a few of these things that we can then say, well, that would be the end point, and then we can follow them through registries to see, well, actually, how many did actually lose their graft and whether that was beneficial. So I think we ought to bring the modern tools to this problem in our trial design, and how we bring that together. And we're going to have to work cooperatively because we need large trial cohort groups. So I think this would be a great area in which to start the new sort of transplant cooperative trial regime, where we bring in new innovative trial designs. That would be my hobby horse, I think, coming from this.
So great thoughts for all of you in terms of the trial design, and that's the surrogate endpoint aspect, at least for clinical trial design, is undergoing the iBox, we'll mention it, is undergoing evaluation by the EMA right now in terms of being a potential surrogate for the development of new immunosuppressive therapy, and there's a parallel effort for its submission to FDA through clinical path, CPATH, and the Transplant Consortium. So that would be sort of, that's over there, because I think that's really more of an industry based. But I think what you're getting at, Phil, is that we would do international cooperative trials, much like oncology did. And oncology has an advantage, and cardiac has an advantage because they've got like 1,000 people in one country or hundreds of thousands, and they don't have to cross borders. But I agree with you. I think new trial designs and coming up with different these composite endpoints, I think, are important. And you know, there are agents out there. There just isn't a ton of new things that we can try. I guess Sindhu probably knows most because she's, you know, at UCSF where things seem to happen. But, you know, in all seriousness, I mean, I think there's one way to go there. You know, Tom is saying, well, there's lots of immunomodulatory drugs. And I suppose, you know, we looked at TOSI and Tregs. I agree, Tom, there's things out there. It's just, you know, it's great to say you're going to do a trial, but getting industry to pay for the drug is one aspect that we have to think about. Not that I'm being a doggy downer. I'm just giving you the brutal reality of we were trying to do an SGLT2 inhibitor international trial. It's going to be $20 million to get drug just to put patients in a trial. So I don't want to be a downer. I also want to make sure that we're clear of what these immunomodulatory drugs are doing and what our expectation is. And I've seen tocilizumab being used quite a bit now and not exactly sure if it's working and what it's supposed to do. We had a couple of other questions in the chat. Someone was asking if there's differences between steroid-free and steroid-containing regimens in terms of the outcomes of the impact of borderline and other rejection episodes. And I want to say that my recollection of Rampersad study is there was one that was steroid-free, where it didn't appear to matter what you did. I mean, I think that's what was so striking. Granted, it's a meta-analysis, and she started with thousands of studies and ended up with 12. But I think that it was just disappointing, right, to sort of see that it almost didn't matter. And it makes you sort of go back and say, like, what do I really know about T cell and T cell biology? And maybe the animals weren't telling me the truth, because it seemed easier to control rejection in a bunch of mice or non-human primates.
Ross, I think we have to emphasize, Phil, from my perspective as a pathologist, said something very revolutionizing to our field.
What?
That T-cell mediated rejection is what we randomize for in our trials, and not the endpoint of a trial. My understanding is that all trials in transplantation, biopsy-proven rejection has been the endpoint and not the target of what we test for to treat it, not to avoid it, but treat it, right? And I think that's a total dogma shift. When I understood you right, Phil, is saying we identify patients with T-cell mediated because we know it is a surrogate for persistent inflammation. That's what these papers show.
Well, if you got 80% of your patients not getting T-cell mediated rejection and they're doing okay on what you've got, it's going to be hard to show in 2 years that they're doing better on something else.
That would be like enrolling 80% of your patients into a breast cancer treatment trial having no breast cancer.
Right.
Yeah.
Right. And you wonder why treating breast cancer has no outcome and your trial fails. So I think the design is one thing, but the other thing is to convince regulatory bodies that we need tailored trials for antibody-mediated rejection with different endpoints, for T-cell mediated rejection with different endpoints, with BK with different endpoints, and I'm not even sure what biopsy-proven rejection is as an endpoint anymore. Any rejection, right? And I think that's a real dogma shift. And we can only get the power in the trials, as Phil pointed out, when we have a more efficient network of enrolling, and we see the challenges with the ongoing ABMR trials, right? But that is the first trial which puts it, risk stratifies for enrollment and has different endpoints and surrogates as the classical across the board immunosuppressive trials had, which were the big success in the field I don't know now, 20 years ago, right? So to me, I think that is these papers give us strong evidence to go down that path. And that's a real transformative direction in how trials are done in transplantation, from my perspective.
I think that's right. And I think it will drive use of those other immunomodulatory agents, because if we then identify a clearly described subpopulation of people at risk and they're doing poorly, that's a totally different argument about why you would use a more costly agent and maybe getting those into the field than looking for a group where people say, well, 80%, everyone's doing well because 80% are. So I think we need to divide things in a way that we look according to risk and how they're doing, and not, as in breast cancer, I think was a good example you used. Not all breast cancer is the same. Well, not all transplants are the same, and some of their outcomes are not as good as we want. So that's the important point. The other final point I just wanted to make was, when we've been doing the transcriptomic studies here over several of them, what we've noticed that was that even in biopsies that be struggling to make subclinical rejection, there's sort of, in a lot of them, there's a lot of transcript evidence of upregulation of interferon gamma related pathways. Mm-hmm. So in transplant, in immunosuppression, we don't really get suppression. As what we get's an armed truce. And in some situations that's better in some people than other, but I think for the vast majority of patients, there is just grumbling underneath this level of alloimmunity. So some of it comes up as subclinical and some makes it to BAMF1A, but I don't think there's many patients currently where it's, happy days.
You mean happy days, okay, I'm done with my rejection and then everything's back to normal?
Yeah, I think, yeah, you've just brought things back into some level of
accommodation. I don't want to use that word.
Of a balance between the drugs you're using and their immune response. With time, that balance gets more in the way of the drugs, I guess, but most people who stop their immunosuppression regret it. That's the normal outcome from my prolonged experience. So alloimmunity's forever there. It's just, for which patient is the risk of increased immunosuppression worth it? Because
from a scientific perspective, I would challenge what you say. And that was one of my notes here when I read the Rampasam paper is, as Ross said in the opening statement, there are some patients who had 10 episodes.
Crazy.
Right? So is episode 10 qualitatively the same as episode 1? The key question we discussed at Banff is an early eye the same as a later eye ifter in terms of qualitative inflammation? Mm-hmm. And I haven't seen yet a study from an immunological perspective, and it comes back to what Tom put in the chat. Do we need different immune modulatory drugs when you have more eye ifter and tubulitis than only tubulitis and eye early post-transplant? Mm-hmm. And I'm saying, okay, we're not there yet. We're still before that, where we separate out TCMR. But I would challenge your concept of saying it is the recipient, which this paper suggests. It's your applet mismatch immunological risk is a strong component, but there's 20% of those with multiple rejection episodes who are low immunological risk. Is this compliance, or are they quantitatively different, how they present later, and they have a self-perpetuating alloimmunity right in the so I think we still don't understand those mechanisms. We have the early picture of how T-cell mediated rejection works, where we do not know what the evolution of immunity is. And maybe we can learn from vaccine, right? We know that several boosters and exposures give you different immunity. And maybe that's the same what you have when you have several episodes of rejection in the same graft.
we're going to be running at, we're actually running over, although as I see, we're not seeming to run out of time for our own comments. There's a couple more things by Tom Blythe-Hansen about immunomodulation and not sort of bluntly slamming the immune response and thinking about, he used now the word tolerance. Next, there'll be the word xenotransplant. So I'm getting a little nervous. But again, the notion of, and this goes back to the question of regulatory T cells and, how to modulate. And I have to say that it sounds adaptive regulation. Well, it sounds all great until somebody shows up and they've got a 2B with tremendous amount of edema and hemorrhage. And, your first step is thymo and steroids, and you try to really whack it down. And so I don't know that if you can talk about immune modulation when you have those vigorous rejections that we've all seen, maybe related to non-adherence, maybe because someone was sick and they didn't take their TAC and they vomited for the last 5 days, something like that. I think we probably need to wrap up because we're going to degenerate, I think, here. And I see somebody did ask about Xeno. In terms of any last comments or thoughts from the panel about either these papers, TCMR, I've heard a lot about trials. We've heard a little bit about transcriptomics. Interesting that we're now, Phil, and I'm sure you guys are doing some spatial transcriptomics. So we're now seeing populations of cells that are present in rejection that we've had thoughts about, but we weren't really sure what they're doing in the crosstalk to innate immunity, which isn't really well managed by our typical T cell agents. So again, yes, it's important to think about immunomodulation, but how that's about to happen, I'm not clear. So I might have to put Tom on the hot seat next time when we do this conversation in April. Sindhu, any last thoughts?
Yeah, I think I would like to make a couple of points. One is that, both of these studies to some extent relied a great deal on surveillance biopsies. In Dr. Rampersad's study, half of the biopsies were surveillance biopsies. They were doing them at 1, 3, and 6 months and at some point, and then they moved on to doing them at 6 months. I think it really tells us there is the iceberg, the tip of the iceberg, the clinical rejections, and that we all know this. And I think Dr. Fleckner also brought this up, the question of what is subclinical, and are we picking up, at least that's what I understood from it, are we picking up a clinical rejection on its way to becoming clinical, or are we picking up something that remains smoldering under the surface? So there are all these different definitions, but we still don't know the scope of the problem. And in the absence of these clear biomarkers, we still have to rely on biopsy. So does this, I think it brings up the question of clinically, are we treating everyone pretty much the same? And what is the role of risk stratification in terms of this molecular mismatch and doing these biopsies to identify a cohort which can then participate in prospective studies, potentially maybe Dr. Nickerson is planning some of these studies to intervene in these groups and diagnose people at higher risk. And the second thing is that the treatment, even the standard treatments that we have, we are not using them the way they were designed. In some ways, if you look at the thymoglobulin package insert, the treatment is 1.5 milligram per kilogram for 7 to 15 days. And this was for treating steroid-resistant rejection. So we have not really, I think, exploited potentially even the full potential of our treatments, because we have no idea without the standardization of a dose and looking at the histologic resolution of rejection, because over times, I think these dosings have shrunk because people have relied on clinical resolution of rejection. And maybe that does not need to be the case anymore. And we need to have more, a more precise sense of when rejection is actually resolving. And that will help us to tailor these existing therapies and potentially come up with new therapies.
Jermaine, any other last thoughts?
No, I just thought it's a really good collaborative effort now to actually start thinking about multi-center, multinational trials. In addition to all the wonderful histology, we also have wonderful registries, which we can definitely follow our patients in the longer term. So something to think about again in a trial design.
Michael, last thoughts?
Just congratulating the authors to wonderful papers, right? Which I think really advanced the field with novel insights, and I enjoyed the discussion tonight very much. And and gathered a lot of ideas. So thank you for the opportunity.
Phil, I know your hand is still up, but I think it might have been up from before.
Sorry about that. That was
Any last wise words?
Oh, gee, I know about wise, but what I would say is just reiterate, I think what everyone's saying. These papers have been very useful in identifying a problem that we should have probably identified some time ago. I think the challenge will be, how do we work cooperatively to find some meaningful answers? And I think it's a great opportunity, and this would be a great first type of trial that we could try and get up off the ground. So let's hope we can work together to do that.
And find funding agencies that are also supportive. But Phil, I would say, because you and I are probably older than some of these other folk, but I think what happened is, I was a medical student, a resident, and I remember going in round on rounds, and even as a fellow, and you'd have people rip-roaring rejection, and they lost their grafts. It was, and then they had CMV, which was the other real scourge of my fellowship. But I do think that we got complacent a bit because the rates went down dramatically. We were starting to do steroid free, and we were getting away with it. And then we saw this dissociation, short-term graft survival, great. It was, I think, the persistent, lack of significant impact on long-term graft survival has been a problem. And it's just taken constant people thinking about it. And I agree, I appreciate Peter thinking about it. I think a couple of other groups have been thinking about it quite a bit. Pittsburgh, Dr. Vincenti at UCSF. Some of us have been sort of batting this back and forth. And obviously T-cell mediated rejection is an important topic at BAMF. So I want us to see this as a positive move forward and an opportunity. I want to take this opportunity to also remember to include children. And again, your point is well taken, Tom. Certainly, Mike Seifert's study is included in the Rappersam paper and showed, pretty poor outcomes, and kids do need follow-up biopsies as well. But thanks everybody today, tonight, tomorrow, this afternoon. I think you guys are a day ahead. Is it a nicer day tomorrow? Let me know. I'm not sure my horoscope goes out that far. But again,
the whole state's underwater here, so we had an inch of rain during this talk. So it wasn't.
Well, I have like thunder and lightning and hail, so I keep looking at the light flickering and the door keeps banging. So I'm glad that I made it. But thank you all, in spite of this pandemic. And if for those of you that want to attend again, we will be doing another live panel with some other panelists on April 11th at 8 a.m. Pacific time, 11 a.m. Eastern time. You're welcome to join us again and join the chat. Thank you again so much for your participation tonight. Take care.